Just leave it be. Somebody help us! We're right there! We need help! I need the help. It's over there. We need help! Over here!
These are not victims of a terrorist bombing, a chemical accident, a plane crash, or a hurricane. They are actors portraying victims in a simulated terrorist attack as part of an exercise designed to test the medical capabilities during a mass casualty event in the National Capital Region. The Medical Reserve Corps sent 21 volunteers to this collaborative multi-agency exercise with the National Naval Medical Center, the National Institutes of Health Clinical Center, and Suburban Hospital in Maryland.
We thought that this was an ideal situation for the MRC involvement because if there was ever a national mass casualty event that overwhelmed the federal responses, they would likely require some support from Medical Reserve Corps volunteers. So this was a good way to test in a controlled situation how MRC volunteers might be used and also to give those volunteers a little bit of experience in seeing what a multi-agency mass casualty response might actually look like.
This was in late October, and so preparations were underway for the inauguration in 2009. Now, we weren't sure who was going to win the election, but we knew that there definitely was going to be the inauguration, and there was going to be a lot of people in D.C. And so the scenario was what would happen if there was an incident that would occur during that inauguration, and how would the hospitals in the D.C. area respond. And so basically, on the grounds of Bethesda Navy, they had a van that breached the security and simulated an improvised explosive device detonating with the release of a chemical agent. They had simulated casualties, about 75 casualties that were made up by professionals, and so they were moulaged, so they were very realistic appearing. And there was a wide array of entities that responded to this disaster like they were real patients. It was treated as a real scenario, and they tried to establish that it was as real as possible, went through all the things that you would do with real patients.
This exercise was the culmination of 3 days of intensive training by Medical Reserve Corps volunteers in the fall of 2008. Planning began months earlier.
We started in the spring of 2008, and this was going to occur in the fall. And we sort of knew the way we wanted it structured. We wanted some classroom time, but we didn't want people sitting looking at PowerPoint slides. We wanted it to be very dynamic, very interactive. And then we thought it was very important to have a field experience where they could take the lessons they learned in the classroom setting and apply them out in the field. And so that was our goal. And we reached out to several partners, and the Navy was very excited to have the opportunity, because if this were to really occur, they could certainly envision a scenario where they have to reach out and have civilian volunteers augment their staffing. And so they were very keen to sort of start this process and involve us in their training program.
I got another immediate for you.
Over 250 MRC volunteers from around the country applied for this deployment training. Unfortunately, we were only able to have 21 participants, so it was a pretty rigorous selection process.
In some cases, it was heartbreaking because all of us in that selection process had to put people in the stack that maybe we'll have to take next time, but just weren't able to accommodate. But the things we looked for in general, we wanted to see that person's commitment to their local Medical Reserve Corps unit. We thought that would be a good measure, that they would be somebody that would be beneficial to a federal deployment. We looked at their previous disaster experience. We tried to get variety in terms of professions.
We had physicians, we had nurses, we had pharmacists, we had other medical providers, some public health professionals. But we also had some non-public health professionals or non-medical professionals as well.
I think we really succeeded. I was very happy with the individuals, and I think they really got a lot out of it. Day one was devoted to our volunteers learning about the federal government and how it responds to a disaster. And this was, I think, new to a lot of our volunteers, many of whom had disaster experience in their local communities. But what we did is we taught them about the different areas of the federal government that are responsible for disaster preparedness and disaster response.
It was really a chance to talk about how the course participants would fit in a federal response, the emergency support function aid, or the public health and medical response to a national emergency.
One of the neat things we had the opportunity to do was take them to downtown D.C. and have them visit the Secretary of Health and Human Services Operations Center, where during a public health emergency, the Secretary basically has multiple TV screens, multiple data inputs where he's able to or she's able to keep track of the emergency, whatever nature it might be. And our volunteers got to actually sit in the seats there where the Secretary receives the briefing and talk to the staff there, and they were able to learn exactly, what kind of information is available to the Secretary during a disaster. We received a lot of positive feedback about that experience.
They actually had an opportunity to meet with the Assistant Secretary for Preparedness and Response, who explained to them how important they are, not only in their local response, but how important they would be to a federal response as well.
This is what people would carry on a strike team.
During this day, they also got some hands-on experience with some of the deployment equipment, some of the medical supplies and equipment that would go out with a federal response team.
Disposable scalpels.
Day two, we had subject matter experts from the CDC. We had Dr. Mark Keim, who's highly renowned and an expert in disaster response and disaster preparedness, is internationally known. And he conducted a specialized training for us, and he was fully aware of the Medical Reserve Corps and previous training these individuals had had. So he developed a course curriculum for us, and it was very, very well received by our volunteers.
The classes were very dynamic, they were very interactive. They focused primarily on issues that arise from man-made disasters, like a dirty bomb or a chemical attack or a bioterrorism type attack. They learned how to put on some of the personal protective equipment that they would need. They learned the knowledge that they would need to understand the difference between the different types of chemical agents, the different types of biological agents that might be used, how to respond to these various agents, how to respond in a radioactive or radiological type of situation.
A lot of the class sort of learned from each other. We had folks that lived in Washington State who had responded to floods. We had folks who had responded to hurricanes and Hurricane Katrina. We had folks who had been through tornadoes and just all these different types of disasters. We had folks who had served in the Army and were actually taking care of casualties in that aspect. And so it was a great interaction and a great dynamic between the classes. They learned from each other in the course of these lectures and classes.
Early in the morning, we were able to go to Bethesda Navy and to take part in some of the pre-briefings, things that had happened at Hurricane Katrina, lessons learned from other deployments and other training opportunities. Then each of us were assigned a role and a position to be observers in this exercise. For me, it was very interesting to watch the staging, the receipt of the ambulances, the patients coming off of the ambulances and being decontaminated. They had large tents with showers and decontamination equipment. Patients were then taken on into other areas where they were further treated, and just observing all of that was very interesting.
We tried to match up the skills. There were several different areas. We had a decontamination tent. There was an initial triage scene. There was a mobile field hospital. So we tried to match up each individual's skills with where we thought that they would learn the most. We had some people that were interested in decontamination, some people that had a background in sort of emergency room. We would put them in the mobile field hospital. The folks that were interested in decontamination, we'd put them at the decon tent. So we really tried to match up folks with where we thought they would be the best fit.
There is no replacement for physically participating in an exercise. We were able to actually see the flow of an event from the initial event through receipt of patients, through record keeping of those patients so that we didn't lose anybody. We were able to see where things worked and where things didn't work.
You can talk to me, that means you can breathe. That's first, so come on up.
I think there definitely were challenges. Communications are always a challenge, so just being able to speak the same language with some of these response partners from various agencies, from the Department of Defense, from local agencies that they don't usually work with. That's always a challenge. And so giving them that ability to practice that in an exercise scenario was important. I think it helped them to better understand what their role might be in a national public health emergency. I think many MRC members definitely have an idea of what their role is in their local community if there's an emergency, but we're still developing in many ways the role for the MRC members in a national type of event. And so this was a first chance to test out what some of those roles might be and to give those participants some comfort level if they were ever called to act in those roles.
When we planned this training, it was very important to us that we got a lot of feedback.
There is nothing to replace hands-on training.
They gave great suggestions for improvement for the future.
We just let the class take over basically and tell us what they liked and what they didn't like.
You can do textbook, you can do classroom, you can watch videos, but to actually be part of an exercise is very important.
All of them improved. The average improvement was over 25%.
Several of our folks that participated in real-life disasters, they were able to use some of the principles that they used during this training as they responded to those.
We hope to continue the federal deployment trainings. We think it's very important to build on these efforts to have MRC members trained, not only for their own peace of mind and their own safety, but also for the overall credibility of the MRC. We want to make sure that everybody knows what their role is, knows that they can handle what the situation might bring up.
And now a message from the Acting Surgeon General of the United States.
The mission of the Medical Reserve Corps is to engage volunteers to strengthen public health, emergency response, and community resiliency. The MRC was founded in response to the 9/11 and anthrax attacks. The Medical Reserve Corps was developed as a way to identify, credential, train, and organize medical, public health, and other volunteers in advance of an emergency. It was quickly discovered that MRC volunteers could also be used to strengthen and support ongoing local public health needs. The MRC began in 2002 with only 42 units and has since climbed to more than 790 active units and over 170,000 volunteers. MRC units are community-based and function as a way to locally organize and use volunteers who want to donate their time and expertise to prepare for and respond to emergencies and promote healthy living throughout the year. MRC volunteers supplement existing emergency and public health resources. As the acting U.S. Surgeon General, I have asked MRC units to help strengthen the public health infrastructure of their communities and improve public health resiliency by working on several priority areas. I ask all MRC units and volunteers to serve as my ambassadors as they work towards increasing disease prevention, eliminating health disparities, and improving public health preparedness. MRC volunteers include any medical and public health professionals. These may include physicians, nurses, pharmacists, mental health professionals, veterinarians, and many others. Other community members can fill key support positions in operations, logistics, planning, administration, and communications. For example, during Hurricane Katrina in 2005, an estimated 6,000 MRC volunteers supported the response and recovery efforts in their local communities. In addition to this local MRC activity, almost 200 volunteers from 25 MRC units were activated by HHS, and more than 400 volunteers from over 80 local MRC units were deployed to Red Cross disaster operations in areas along the Gulf. During Hurricanes Ike and Gustav last year, over 1,500 MRC volunteers from 63 MRC units responded in their local areas, working over 30,000 hours in a wide array of roles and settings. The MRC continues to grow and create new opportunities for national response. Legislation is passed to allow MRC volunteers to deploy with the Department of Health and Human Services as part of the federal emergency response. We're also establishing new policies and procedures to facilitate this growth. MRCs will continue to play a key role in emergency preparedness in this country. I appreciate the efforts of each and every one of you to participate in this effort. Thank you very much.